48%. 48%. Uganda has contained its outbreak with 20 confirmed cases, while one imported case was reported in France. The immediate challenge, therefore, remains the very large and geographically expanding outbreak in the Democratic Republic of the Congo. Next slide. Today, 26th of August, marked the 42nd day since the last confirmed case was discharged from the treatment center in Uganda. That means 2 full incubation cycles, making sure that no more residual risk of Ebola is in the country and making the end of the outbreak in Uganda. Can we applaud Uganda? Next slide, please. So now let's focus on DRC. In DRC, we have 6 provinces and 58 health zones are now affected. For those who are not familiar with DRC, a health zone can be larger than my country. I'm from Haiti. My country is only 26 kilometers square. And in DRC, one health zone can be bigger. And the health zone is the administrative division of the health sector. It is important to note also that we have good news in this outbreak. 1,245 patients have recovered from this outbreak. And however, Ituri, the province of Ituri, carries the overwhelming burden with over 4,700 cases. Next slide. Geographically, this outbreak is heavily concentrated. In Ituri province alone, as I already mentioned, accounts for 84% of cumulative cases and 78% of deaths, with nearly 8 in 10 of his health zone is already affected. Next slide. This is the epi curve. I mean, there's a special evolution of the outbreak. This shows you how daily and weekly the outbreak is evolving. We can see in that graph that transmission remains very active, and the recent weeks reflect both ongoing spread. And here the message I want you to have is that we have slowed the acceleration, but we have not yet bent this curve. That is the task that we have ahead altogether. Next slide. This map shows why this outbreak cannot be treated as a purely national event. The affected zone sit astride major mobility corridors. Mining routes, trade roads, and cross-border movement toward Uganda, South Sudan, and Central African Republic. People move and the virus moves with them. Every corridor you can see in this map here is a potential export pathway. Managing transmission, therefore, means managing movements, screening at point of entry, and coordinating across borders. Next slide. The demographic matters also. Who are the most infected? We can see the most affected group is the working age adults, 18 to 49 years old. Women represent 53% of reported cases. Most are striking and most painful, children under 5 have the highest case fatality ratio, and around 60%. This pattern shaped our clinical priorities. Pediatric care is highly needed, maternal services, and they remind us that this virus is hitting the most vulnerable population. Next. This slide breaks what I just said. This is the fatality down by age and sex. While females are the most affected in this outbreak, males are dying more in this outbreak. You can see that females are dying at 35.2% and male at 40.8%. So the pattern is really consistent of what I said before. The very young, as you can see, in place, the older age group carry the heaviest fatality. Children under 5 are dying at 69.5%. Next slide. This slide is, for me, the single most important operational slide. It is a high proportion. First of all, in blue, you have the death in community, and in green, you have the death in the ETU, in the Ebola treatment units. You can see that there is a high proportion of deaths are occurring in the community, not in our treatment center. When people die at home, they were not isolated, their contact were not traced, and unsafe burial can seed new chain of transmission. That means community deaths are both a measure of where are we failing to reach people early, and also a driver of continued spread in the community. Next slide. We have the key risk drivers. The bottom line I want you, Excellencies, Honorable Minister, to take from this section is the response is not struggling because of any one factor, because of one single factor. We have a combination of those factors. First, the hazard itself. It's very serious, often fatal virus with no vaccine or specific treatment. Second, delay in detection. I just inform you that the virus has been there since February and we detected it in May. Weeks passed before confirmation. Third, we have the breaches in infection prevention that is reflected in a lot of number of healthcare workers infected. Fourth, we have sustained community transmission through family, through healthcare center, and also to unsafe burial. And fifth, we have the insecurity that limits our team access. And sixth, regional mobility that I showed you that raise the risk of export. That means there is not a single driver explain this outbreak. As I mentioned, it is a combination of all of those. Next slide. Now I will go to operation. How we turn to operation. What are we actually doing on the ground, pillar by pillar? I will walk you through how the response is organized, how are we conducting surveillance, diagnostic, case management, infection control, and community engagement, and how are we protecting essential services at the same time? Because women continue to deliver, children continue to need their routine immunization. I really want you to see not just the scale of the challenge, but the scale of the machinery now working to meet it. Here you can see the organizational of the response. The response is government-led, and I want to stress that. It is government-led and partner we are there to support. There is a three-level architecture that has been put in place. We have the national leadership, through the coordination platform, the provincial cells across the affected provinces, and the health zone teams that are anchored in communities. So 95 partners are mapped against gap to reduce duplication. We have a coordination where all partners are sitting together so that we mutualize our effort. Next slide. Excellencies, this outbreak is not happening in isolation. In the 58 Ebola-affected health zone, Ebola is colliding with a pre-existing humanitarian crisis. Humanitarian coverage in these zones is dangerously low. I repeat, is dangerously low, often below 40% for water. Those populations, they don't have access to water, to clean water. Access to health is very low. Food security. In this place, we have a very high level of malnutrition. That means roughly 1.5 million people not reached with food assistance, and 1.7 million without essential non-Ebola health services, and 833,000 without adequate water and sanitation. Next slide. On surveillance, we have done better now. We are seeing some progress. Contact follow-up has improved from around 40% to roughly 85%. We have received about 76,000 alerts, verifying over 84% of them. More than 22,000 contacts have been listed. At point of entry, over 11 million travelers have crossed, and nearly all were screening during the 500 days of the response. However, we need to be also conscious that daily follow-up is still below our 95% target, and our contact-to-case ratio remains too low. We are improving. We are not yet there, but we need to be there. Next slide. Diagnostic capacity has expanded substantially. 21 laboratories are now active, from 1 to 21. We can say we have done a lot, with 5 more decentralized labs coming online and a further 10 to 20 in planning. We have reached a daily capacity around 3,000 tests. Critically, phylogenetic analysis is also available, and the new analysis we have, they point to a new zoonotic spillover followed by human-to-human transmission. And that gives us reassurance that there is no evidence of viral mutation so far. This is a good news. That's bringing testing closer to patients, and one of the clearest ways we shorten the time from onset to isolation. Next slide. On case management, we have 10 partners in the field supporting the ministry across 49 treatment centers, with over 1,300 active beds and around 800 confirmed cases hospitalized today. So we expect to reach nearly 1,700 beds by mid-September. That's been allocation accordingly to epidemiological trend, and also including dedicated pediatric, critical care, and maternity capacity inside of Ebola treatment centers. Clinical care is improving with oxygen therapy available. We have oxygen concentrators. We also have biochemistry equipment. An ambulance and safe burial center has been operational, and also a therapeutic trial is underway. So the message here is that if we have better bed capacity closer to the patients, we can save more lives. Next slide. When we look at infection prevention and control, it is organized around the concept of IPC rings. That means rapid action around every confirmed case in the household and also in the health facilities. More than 450 rings has been activated. Over 2,900 households and 850 health facilities have been decontaminated by the team in the field. And more than 1,000 frontline workers are working in IPC only, including safe and dignified burial team. They have been trained, and over 450 exposed healthcare workers have been assessed. So protecting healthcare workers is a priority for us. Safe and dignified burial is also one of our top priorities to stop this outbreak. Next slide. When we look at risk communication and community engagement, we have now operated at real scale. We have already reached over 6 million of population of people. More than 1.8 million of households has been visited one by one, and nearly 60,000 community alert has been generated by the community relays. So activity spans in 6 provinces. All those activities that we are mentioning, they are occurring in all the 6 provinces. We have 6,000 community relays are deployed, and over 100 radio stations have aired thousands of spots, reaching millions monthly. Crucially, engagement is enabled safe burial, contact listing, and rapid rumor resolution. When communities trust us, they alert us earlier, and earlier alert save lives. Next slide. Here, I want you to really see when we say that this response is a community-centered approach. What does that mean in reality? We listen first. We co-design action. We work through trusted local actors, survivors, women, youth, motor taxi drivers. and we link every community action directly to stopping transmission. Community have moved from passively receiving messages when we started this outbreak to actively shaping response decision. Community dialogue is now an operational entry point for case detection, referral, and safe practices. Engagement is not an add-on to communication. It is a control measure for us. To reinforce that point, we have shifted from one-way risk communication to really community-led detection. Next slide. We also move on clinical trial. But I want to be straight with you about the medical countermeasure. There is no confirmed cross-protection between the existing Zaire Ebola vaccine and Bundibugyo. A clinical trial phase 3 will start soon to assess if there is that cross-protection. And so far, there is no Bundibugyo vaccine specific for Bundibugyo. And we are also starting a clinical trial phase 1 for the specific vaccine, and that will take months. So in the meantime, we are also pursuing other clinical trials, like the clinical trial for the treatment with the monoclonal antibodies and the remdesivir, and also the post-exposition prophylaxis with the obeldesivir. So until those clinical trials can deliver our response, can deliver that we have treatment or vaccine, our life-saving tools remain early detection, isolation, and quality supportive care. Next slide. But despite all those achievements in the response after the 100 days in DRC, we still have some challenges. We still have insecurity and armed group activity that restrict access and have led to incidents affecting our facilities and operations. Community trust, even though we are working with them, but community trust remains fragile in some areas. And with episodes of resistance and burial practices that really complicate unsafe burial. And we also have to tell that the countermeasure and financing. We face the absence of an effective vaccine and treatment, and a response that is still under-resourced relative to the scale of this outbreak. These are the obstacles standing between us and control the outbreak. Next slide. However, to date, our logistic and operation team have successfully established a resilient, rapid response supply chain, distributing essential medical supplies and personal protective equipment across all high-risk zones, but yet we are now facing a critical 30 million funding gap to sustain this operation with only the logistics. Next slide. This is a specific need of another 20 million to secure critical supply chain in the Democratic Republic of the Congo. So, and without this immediate investment, we risk stalling the momentum we have built and compromising our ability to maintain the life-saving services delivery to the community that they need the most. Next slide. We also integrated the prevention of sexual harassment across this BVD response. I really want to emphasize that community protection, protection the people, protection of the most vulnerable, of the people we serve, is built into this response. We have integrated the prevention of sexual exploitation, abuse, and harassment across every pillar. Under a government-led, the government also have that pillar, interagency mechanisms, the UN, we are supporting the coordination. We also have community-based complaint and referral channel that has been established. We have risk assessment that has been conducted and led by the community. We also put in place some mitigation measure that has been identified with survivor-centered approach. This is an emergency, a very big scale of emergency. Therefore, safeguarding the community protection is not optional. It is a measure of the integrity of our collective response. Next slide. So now we will switch to preparedness. I now turn really, because It is where honorable minister outside of DRC have the most direct stake. Containing the outbreak at source is our first line of defense. But every neighboring at risk country must be ready. In this section, I will show you our assessment of spillover risk, the state of readiness across the region, and the simulation exercise that we have conducting in some countries to support them. This slide shows you our spillover risk map, and it has changed in just 2 months. In May, Uganda topped the risk ranking, but August, with Uganda's outbreak contained, the risk has moved northwest. The Central African Republic is now our highest risk country, followed closely by South Sudan, because the epidemic has reached their adjacent border. My key message for you today, act on the risk score, not the case count. South Sudan surveillance gap put it at an imminent risk before case number would ever trigger a reaction. Next slide. This is the status of readiness for the Bundibugyo threat as of July. We have supported at-risk countries to complete readiness assessment, and a number of high-risk countries now have contingency plan and budget in place. But readiness is uneven. Some countries have moved quickly, others have gaps in key capacities. The purpose of showing you these, honorable ministers, excellencies, this is not to grade any member state. It is to identify precisely where support and investment must go now, while our caseload are still 0. Next slide. To make readiness real, we have run simulation exercise across the region. 20 exercises have been conducted, engaging 15 countries. 10 countries are already implementing the key recommendations that emerge. 5 are still to confirm implementation, and we are following up with them. Simulation exercise is a very important exercise as it will expose the weak point, coordination, isolation, sample transportation before we have a case in the country. I really encourage all member states, every member state represented here, to complete this simulation exercise and crucially act on their recommendation. Next slide. So what now the shift in the strategy in the response in DRC? In this slide, we capture a deliberate shift in the response. We are moving from pledge to disbursement so that community become operation on the ground. We are scaling up community-centered approach, expanding bed capacity, and reinforcing contact tracing and active case searching. We are enhancing preparedness in high-risk zone, and we are working to enable humanitarian trust so we can reach affected community. In short, we are moving from planning to execution and from centralized messaging to community-led action. Next slide. This is the current funding situation. Against a total requirement of 518 million under the Continental Emergency Plan together with Africa CDC, we have secured 1.3 billion in pledge, but with 150.5 million committed and 323 million disbursed. Importantly, WHO has directly mobilized 91 million with a further 25 million in the funding pipeline. So the funding mix also demonstrates the strong contribution of external partners alongside domestic resources. The Democratic Republic of the Congo has disbursed 50 million to contribute to this outbreak. And so far in Africa, 18 countries have contributed. Going forward, our focus should therefore be on accelerating commitment and disbursement and ensuring that available funding is strategically aligned. Next slide. This progress would not have been possible without the strong commitment of support of our donors, of our partners. We would like to express our sincere appreciation to the United Kingdom, Germany, Australia, the United Arab Emirates, Italy, Denmark, and the Netherlands, as well as the European Union civil protection mechanisms for their continued support. We are equally grateful to our global health and philanthropy partners, including Gates Foundation, the Global Fund, Novo Nordisk Foundation, the Children Investment Fund Foundation, and the Wellcome Trust. We are also deeply value the contribution of the UN Central Emergency Response Fund, Africa Development Bank, and World Bank. Each of these partners have been instrumental in strengthening preparedness, enhancing response capacity, and enabling countries to better manage emergency. So thank you to all of you. Next slide, please. Honorable ministers, the previous slide. Honorable ministers, this slide brings me to what we are asking you today. We have 5 priorities we would like you to support us. First, let's have one voice on secure humanitarian access. Let's implement the initiative that you approve in the World Health Assembly, Health for Peace and Peace for Health. Second, increase and accelerated funding for both preparedness and response. Third, strengthen cross-border collaboration and lift travel and trade restriction in line with IHR recommendation. Fourth, let's integrate standardized emergency curricula over the continent at medical and paramedical school, because so many of the people you train, you invest in, are losing their life when there is an emergency, because they are not trained in infection prevention and control, they are not trained in surveillance system. We are waiting for them to work so they can receive training. Those trainings should be part of their core curricula the time they are still at medical school or paramedical school. And fifth, consistent member state contribution to the African Public Health Emergency Fund so we can strengthen Africa emergency preparedness capacity. Honorable ministers, excellencies, let me remind you that this outbreak is serious and it is not yet contained, but it is not beyond our collective reach. With the access, the financing, and the solidarity, we can bend this curve and protect the communities and the border we all share. Thank you. Merci beaucoup e muito obrigada.
Merci beaucoup, Dr.
Thank you very much, Dr. Belizer. I now open the floor to African member states for their interventions.
La Zambie, vous avez la parole.
Zambia has the floor, followed by Uganda.
Chairperson, Zambia appreciates the update on the Bundibugyo virus disease outbreak and commends the affected countries, WHO, Africa CDC, and partners for their continued response. Given our geographical proximity and extensive population movement along trade and transport corridors linking Zambia with the Democratic Republic of Congo and the wider region, this outbreak remains of particular concern. Zambia has therefore maintained heightened preparedness, emphasizing early detection, rapid investigation, and containment of any imported cases. Our National Public Health Emergency Operations Center has been activated at grade 2 alert mode with strengthened surveillance, laboratory readiness, infection prevention and control, case management, risk communication, and points of entry preparedness. By early July, Zambia had investigated 5 alerts, all of which tested negative. These investigations provided valuable opportunities to test our systems and identify areas requiring further strengthening. Our experience underscores three priorities. Preparedness must extend to subnational levels, cross-border information sharing must be rapid and consistent, and countries require sustainable access to PPE, laboratory supplies, trained SAGE personnel, and appropriate isolation capacity. Zambia therefore calls for continued regional coordination and partner support. No country can adequately protect itself in isolation. Regional preparedness must translate into coordinated operational readiness across borders. I thank you.
L'Ouganda, vous avez la
Uganda has the floor, followed by DRC.
We want to appreciate the presentation by WHO on the current Bundibugyo outbreak. Uganda wants to add its voice to thanking the many partners not yet listed on those who have responded and supported the response to Ebola. I realize that list was not exhaustive. Secondly, we want to appreciate the President of Uganda for allowing Uganda to deploy its health workers across the border, a true test of solidarity. So as you fund the response, Uganda has already set up 2 treatment centers and 2 laboratory setups, and we are yet currently expanding the 3rd. We look forward to partnering with those who want to support DRC through Uganda, and many are doing so. Finally, Chair, 30 days ago, Uganda declared the end of our outbreak because this was a unique outbreak of imported cases. Uganda stands to share experience, including sharing with WHO in how to revise the declaration protocols, including treatment, because we've shown that we currently have only case fatality rate at 20%, 10%, not 20. That can be different if you allow WHO also to learn from Uganda. I thank you.
La RDC, vous avez
DRC, you have the floor, followed by Ethiopia. Excellency, Mr. Chair, DRC would like to commend WHO for this presentation. It clearly shows the situation of the pandemic in our country, and we'd like to, and you have reiterated WHO's central role in international solidarity. This is the 16th Ebola virus outbreak in DRC. The 16th pandemic is happening in a specific context. As recalled, you have a context of insecurity, there's a humanitarian crisis and a strong concentration, demographic population and mobility, despite the health system being almost inexistent in the region, we have been able to detect the pandemic, and thanks to the WHO support and other partner support, a response is being organized and implemented, and it becomes stronger every day. In our country, we authorize children's vaccination when it comes to the Zaire strand, because immunization is a hypothesis, and we hope that that will help us contain the pandemic, or this outbreak. So we are also open to trials and research for other vaccines in collaboration with WHO, CDC Africa, and other partners. Currently, we have received 16,000 vaccine doses out of 50,000 expected, and we're still working on the surveillance strengthening, and strengthening strengthening also the response within the community. And the government mobilized and disbursed $50 million in order to boost the response to this outbreak. We remain confident that with the concerted efforts of the international community and regional community, we will be able to contain this this outbreak, and we will be able to cast out this disease from Africa and avoid its spilling over in the whole region, on the whole continent, and in the rest of the world, to the rest of the world. Thank you.
Merci, la RDC.
Thank you, DRC. Ethiopia, you have the floor, followed by Algeria.
Thank you, Chair. Ethiopia would like to update the Committee on our national preparedness and public health measures following the emergence of a Bundibugyo strain of Ebola virus disease detected in DRC and Uganda. Recognizing the risk of the disease, Ethiopia immediately activated proactive containment and readiness measures and has undertaken the following preparedness actions. The country heightened public health surveillance, enhanced points of entry screening, including mandatory travel declaration forms for passengers from affected areas. These operations have been active at international airports and designated ground crossings since May 17, 2026. Since then, the National Public Health Emergency Operations Center at Ethiopian Public Health Institute has been in the alert mode. A comprehensive emergency preparedness and response plan has been prepared across 12 technical pillars. Our rapid response teams have been deployed to high-risk areas to evaluate the readiness of districts, health facilities, and point of entries. Extensive orientations and comprehensive clinical trainings have been delivered for public and private healthcare workers. The field hospital has been designated and prepared as an isolation center. Multiple functional and field-level simulation exercises have been conducted, including one at Bole International Airport and another involving sub-national public health emergency operation centers. Ethiopia remains committed to enhancing its preparedness and response capabilities in alignment with the WHO and Africa CDC Joint Continental Ebola Response Plan. We reaffirm our solidarity with affected nations and remain vigilant in safeguarding our population and region against cross-border transmission. Thank you, Chair.
L'Algérie,
Algeria has the floor, followed by Côte d'Ivoire.
Thank you, Mr. President. Mr. President, we are happy to hear that the spread of Ebola epidemic in Uganda is under control. We expect very soon the same outcome in the Democratic Republic of Congo. Mr. President, this epidemic has demonstrated the vulnerability of the continent and the need to strengthen its health security, including sustainable investment in public health systems. Algeria has always placed particular importance on international solidarity and cooperation in the field of health. Faced with the threat posed by the Ebola epidemic, particularly in Uganda and in Democratic Republic of the Congo, our country has demonstrated its commitment alongside the international community to help contain and eradicate this disease. In this context, Algeria has notably provided the financial contribution to the CDC Africa to support efforts to combat the epidemic and strengthen health response capacities. This contribution reflects Algeria's determination to actively participate in international efforts by supporting countries and organizations involved in the prevention, surveillance, and management of the disease. Through this action, Algeria reaffirms its commitment to the principles of solidarity, international cooperation, and collective responsibility in the face of global health crisis. The fight against Ebola, like any pandemic, requires joint mobilization and close cooperation between states and health organizations. Algeria will therefore continue to support initiatives aimed at protecting populations and strengthening health security, convinced that international solidarity is essential to effectively address major health threats. Thank you.
la Côte d'Ivoire,
Côte d'Ivoire has the floor, followed by Kenya. Thank you, Mr. Chair, ladies and gentlemen. This new Ebola outbreak in Central Africa requires a constant preparedness, strengthened international cooperation, and national systems that can respond swiftly. With all of these challenges, Côte d'Ivoire has strategically decided to invest in a sustainable manner in preparedness rather than response. Given the current Ebola outbreak, or in view of it, our country has activated its national alert and preparedness mechanism under the aegis of the government. A certain number of priority measures were implemented, such as the immediate heightening of epidemiological surveillance on the national territory. We also intensified border control, air, land, sea, with an online platform to monitor passengers coming from risk areas. We also strengthened laboratory and diagnosis capacities, established specialized contact tracing teams. We strengthened communication around risk, communication in planes towards the population, also organized simulation exercises in order to test our response capacity. Our priority remains sustainable capacity building at the national level, and that is why we are strengthening rapid intervention teams, working on also establishing a national emergency team. There's also training of health staff. Emergency logistics are being strengthened. Health surveillance, modern analysis tools for risks are an asset in order to reach our goal, which is early detection, being able to decide quickly and to act more effectively. We would like to commend WHO for its crucial role in this response, and we'd like to thank the various partners and countries for their support. And Côte d'Ivoire is actually part of those who contributed to the tune of $2 million to Africa CDC. Thank you.
Kenya
has the floor. Togo prepares.
Honorable Chair, Kenya thanks the WHO for this special briefing session on the ongoing Ebola virus disease outbreak in the Democratic Republic of Congo. Since the declaration of the ongoing outbreak, Kenya has not recorded a case. However, we fully acknowledge that due to high cross-border movement, trade and population mobility within the region, Kenya is at risk of importation of the disease. In view of this, we have initiated and continue to implement various preparedness measures, including activation of our National Public Health Operations Center, as well as the 26 subnational level emergency operation centers to support structured coordination of preparedness interventions. We have also activated an incident management system, screened more than 487,000 travelers across 26 points of entry. We have heightened our surveillance for the disease since the outbreak began, leading to investigation of 206 alerts. Samples collected following investigation of these alerts have been tested in 5 designated laboratories and all turned negative for the disease. We have trained more than 3,500 healthcare workers at both national and subnational level, sensitizing them on various components of the disease. We have also heightened risk communication and community engagement. Owing to high cross-border movement and population mobility within the region, Kenya urges all member states to strengthen timely information sharing across the borders to inform timely actions. We congratulate the Republic of Uganda for quickly bringing the outbreak there to a control and stand in solidarity with the Democratic Republic of Congo as we combat this outbreak. Thank you.
Thank you. Togo has the floor. Guinea will go next. Thank you very much, Chair. Togo would like to thank the Secretariat for the brilliant presentation that we have just seen about the current epidemic on the continent. We're mobilizing our national emergency team through sustained support, preparing for the response. We encourage member states with advanced experience in preparation of response to share best practice in terms of governance and continuous training. We urge the member states, the partners, and WHO to help in capacity building to deploy people across borders so that nobody is left without the requisite capacity in the face of emergencies. Thank you very much. Thank you very much. Guinea has the floor. Congo will follow. Thank you very much, Chair. Ladies and gentlemen, the Republic of Guinea would like to thank WHO for this presentation on the Ebola virus disease situation in the DRC and Uganda. The experience teaches us that preparation is fundamental. When we are faced with Ebola, we need to be one step ahead in terms of response. Under the coordination of our Ministry of Health, a number of different measures have been undertaken. Guinea has relaunched the agreement for coordination of emergencies in airport environments. So we are strengthening measures in the air transport sector and at points of entry. We've assessed the risks of the epidemic at this level. We've identified capacity building required. The diagnostics teams were employed to help with early detection as required. At the same time, rapid intervention teams have received training in public health emergencies in the hinterland of the country as well, preparing for public health emergencies at all levels. In order to test national capacity, we are planning to engage in a national simulation exercise and cross-border exercise as well at regional level, working with neighboring countries, Liberia, Sierra Leone, and other countries. We are fully aware that preparation requires predictable funding, pre-positioning of inputs and operational capacity. We asked WHO partners and others to support our exercise and to help fill the gap where insufficiencies have been detected in terms of medication, treatment, and others. Thank you.
La parole est au Congo et
Congo, and then the Central African Republic. Chair, ladies and gentlemen, Congo, through me, congratulates the Executive Secretary of the Regional Office of WHO for this very important point on the agenda dedicated to the Bundibugyo Ebola virus. Congo would like to express its solidarity vis-à-vis the DRC that is having to deal with this epidemic, and we would like to applaud the efforts made by the authorities, the communities, and all partners working on the response. Our country has not yet been affected by the Ebola virus. However, our geographic positioning, the borders with the DRC, the mobility across borders, air, river borders, etc., and also border points expose us to a risk of importing the disease. And so we have activated the National Preparedness Mechanism. The National Emergency Center is on alert, and the National Preparation and Response Plan for Ebola has been revised and updated. Surveillance has been strengthened at point of entry, in training, and also at community level. Furthermore, other measures are being undertaken, in particular, control of travelers, tracking of stocks in terms of PPE, and also awareness raising at community level, and also awareness raising in terms of the travelers using French and local languages. We need to ensure capabilities at points of entry, a lack of capacity in terms of training for some public health professionals, and also the need for laboratory capacity in Brazzaville and Pointe-Noire. This is why we restate our commitment to strengthening our preparedness and response mechanisms, working with WHO and the member states, as well as our technical and financial partners. Thank you. The Central African Republic has the floor, and then Comoros. Thank you very much, Chair. Regional Director of WHO, ladies and gentlemen, honorable ministers, distinguished delegates. The Central African Republic would like to thank WHO, CDC Africa, and all other partners for the support given to fight the Ebola virus. The Central African Republic is exposed to a very high risk of importing the disease, namely the Bundibugyo strain, because of its geographical proximity to DRC. We share more than 1,600 kilometers of river borders. We have adapted our preparation based on the 12 pillars proposed by the WHO. After the declaration of the epidemic on the 15th of May 2026, the management committee was activated at our level. Based on the risk levels, 3 health districts were classified as priority level. Communication risk plans have been updated. 79% of community health workers in high-risk districts have been trained in early detection of EVD. Points of entry have gone from 4 to 50. And we are now also collecting numerical data. We are also collaborating with the Democratic Republic of the Congo. Mobile laboratories have been deployed to the districts closest to the risk areas, namely Umbongo district. High-level efforts are being made also to mobilize resources that will allow us to implement our national plan, preparedness plan. Preparedness against EVD was complicated by an outbreak of cholera, which is why our health minister is not here today. He is on the ground dealing with this outbreak. Thank you.
Merci, Elsa.
Thank you very much, Car. Comoros, you have the floor. Thank you very much, Chair. The Comoros would like to thank WHO for having put this EVD issue on the agenda. It is obviously affecting our continent as a whole. The declaration of public health emergency of international concern has led us to take this matter very seriously. Although we do not have borders neighboring with these countries, they're not neighboring countries. However, we do now have more people traveling to our country from all of the countries affected, often trying to get to Europe because we're close to the Reunion and Mayotte. So we are receiving more people passing through from other places in the world, which is why we are preparing for possible importation of the epidemic. And so a number of different meetings have taken place at the level of our government authorities. The Minister of Health, the Minister of Home Affairs, and other units have worked together to come up with a strategy to control migratory flows. A number of different exercises were conducted. We had to review our Ebola management plan. This was updated, and we set up a team that is in charge of managing the first case should one emerge. And we also undertook training of surveillance agents at the borders, and the borders, the official borders now have surveillance because we have porous borders. Clandestine migration is a great concern. We need further strengthening, therefore, at this level. As for challenges, well, the diagnostic element is the biggest challenge. We need diagnostics tests. We have a lack of those. And there's also a matter of PPE, personal protective equipment, specific equipment for EVD. This is what we need to manage cases. Thank you.
Merci.
Thank you very much, distinguished delegate. I see no further requests for the floor from the member states of the region. I invite member states from other regions, UN agencies, and other non-governmental organizations to ask for the floor by raising their nameplates. Thank you. UNICEF, you have the floor. IOM next.
Thank you, Chairperson. UNICEF commends the government of the DRC, WHO, African CDC, partners and communities for their leadership, commitment, and collective effort to contain the Ebola outbreak and protect affected populations. UNICEF would like to emphasize these three key points. The response must continue to protect children and mothers while maintaining access to essential maternal, newborn, and child health services, particularly in the affected and hard-to-reach communities. So the scale and the speed of the response must match the scale of the outbreak. Community trust and engagement are fundamental to controlling Ebola and ensuring people continue to access essential health and non-health services. And lastly, we must continue to learn and strengthen for the future. We must continue to capture and apply lessons from the response to strengthen preparedness, health systems, and community resilience, and reduce the risk and impact of similar outbreaks in the future. Finally, UNICEF remains committed to working alongside the government, WHO, African CDC, partners, and community to protect children and mothers, sustain essential health and non-health services, strengthen community trust, support communities to contain the outbreak, and turn the lessons from this response into stronger preparedness for the future outbreak. Thank you.
Merci.
Thank you very much, UNICEF. The IOM, you have the floor.
As the UN Agency for Migration, IOM recognizes that population mobility is a critical consideration in all outbreak response and preparedness efforts. Migrants, cross-border traders, transport workers, refugees, IDPs, pastoralists, and border communities are often among the first populations exposed to these emerging public health threats, as shared also with member states in this meeting. While they also face major barriers, to this, in support of government-led efforts, IOM has scaled up operations across different countries, which are at risk, as well as those that have been affected, with significant work in DRC, Uganda, South Sudan, Rwanda, Burundi, and other member states. To date, we have mobilized more than 23.6 million USD and provided more than 19.8 million health screenings at 227 points of entry. Through population mobility mapping, IOM is working closely with governments to identify high-risk mobility corridors, congregation points, border communities, and formal and informal crossings where disease transmission risks may be elevated. Lastly, IOM remains very committed to working under the leadership of member states and in coordination with WHO and Africa CDC to strengthen POE preparedness, protect migrants and mobile populations to ensure that our continent is safeguarded in this and any other future outbreaks. Thank you.
Gavi, à vous la parole.
Gavi, you have the floor.
Thank you very much, Mr. Chair and Excellency. Gavi stands with the Democratic Republic of Congo, and Gavi stands with the Democratic Republic of Congo and with all countries in the region at risk of Ebola. To support the response, Gavi has mobilized 50 million US dollars. This includes 40 million to accelerate access to potential vaccine against Bundibugyo Ebola virus, and 10 million to help affected countries, including DRC and Uganda, to protect frontline healthcare workers and sustain essential immunization services. Gavi has also invested significantly in regional coordination efforts through support to key partners, including WHO, Africa CDC, and UNICEF. In addition, through the Gavi-funded Ebola vaccine stockpile, more than 70,000 doses of Ervebo have been made available to support studies on cross-protection and the vaccination of line health workers. Finally, Gavi remained fully committed to supporting the people of Democratic Republic of Congo and all countries facing the threat of Ebola. We will continue working alongside government and partners to support response efforts and help ensure that vaccines can contribute to bringing this outbreak to an end. I thank you.
Merci.
Thank you. The International Federation of the Medicines Industry, you have the floor.
Thank you. Marking the 100th day after the Bundibugyo outbreak was declared, the global pharmaceutical industry underscores its commitment and track record to tackling health emergencies. Within a matter of days after the announcement of the outbreak, biotechnology and pharmaceutical companies mobilized along governments, Africa CDC, WHO, CEPI, Gavi, and other partners to develop new vaccines and therapeutics and explore cross-activity from existing ones for the current outbreak. This rapid response demonstrates the willingness of companies to voluntarily contribute to the collective response efforts and the value of years of prior investment in science, platform technologies, partnerships, and preparedness. We see this outbreak as a wake-up call for negotiators discussing the pandemic agreement's PABS annex. We caution that some proposals under discussion could add complexity and cost to the response to future pandemics and delay access to critical samples and information that scientific research relies on to develop and deliver medicines and vaccines. This will not do anything to strengthen the R&D pipeline either, to improve global preparedness, and will likely lead to fewer companies working on crucial areas of public health during the inter-pandemic period. We call on the PAB system to strengthen the conditions that encourage company engagement in pandemic preparedness and response, including ensuring timely and open sharing of pathogens and data, legal certainty for researchers and manufacturers, predictable rules, and partnerships that allow science to move forward. A complete version of the statement is available on the IFPMA website. Thank you.
Merci.
Thank you. Thank you for these very valuable comments. Are there any comments from the Secretariat?
Oui. Okay. Yeah, merci beaucoup.
Yes, thank you, Chair.
Thank you to all the countries who provide their input and also their appreciation, and also most importantly, what they are doing in order to prepare before they can have a case of outbreak. So regarding the number of partners, I agree that the list is not exhaustive. However, I think I have to make an advocacy for all the donors of the partner that are providing funding to this Ebola outbreak to use the tracking tool, the financing tracking tool that has been provided. It is online and it will be made available to everyone so we can have the information. It is really in terms of transparency, but also in terms of information sharing, so the information can be available and we can also represent it in presentation like this. We really appreciate that, and we will hope that every member state here, we are receiving some funding for this outbreak in terms of preparedness or response, so they can ask them to use the tracking tool so we can monitor those funding adequately. So regarding also the cross-border, I think one of the lessons learned in this outbreak is that a virus doesn't respect borders. So we do not also, think that our border, we can close border. In Africa, we don't have borders. We have population living all over together. They are doing market together. They get married together. They have children across the border. So administratively, we can say we have borders, but when we look at the way of living of our communities in Africa, we don't have borders. So this is why we are having those MOU or Memorandum of Understanding on how to share information, what kind of information should be shared between countries, the real-time sharing information, how we can make more coordination across borders. So now population don't need to be restricted of movement, but they know where the services are available so they can access to the service. So with that, I would like to invite you to the cross-border side event tomorrow at 7, so we can continue discuss that. We have 11 countries that already come together in order to agree in some of them to review that MOU that can really establish this commitment on how we can work together across those borders. So let me stop there. And we also take note of some countries with the lack of tests for of Comor, that we will work together with you to see how we can provide some equipment and also some tests to pre-position those in Comor. And let me say thank you, Mr. Chair, and thank you to all the member states. Thank you to Gavi and all the institutions that are supporting this response in DRC and the preparedness in the high-risk countries. Thank you. Over to you, Mr. Chair.
Thank you very much to the Secretariat. The Regional Committee has taken note of the update on the ongoing Ebola virus disease outbreak caused by the Bundibugyo virus. Thank you all for your very important contributions. This concludes our consideration of this agenda item, special session. Thank you. Distinguished delegates, this concludes our deliberations for today. Before we close today's proceedings, I would like to give the floor to the Secretariat for any announcements or